Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
As we know, acute promyelocytic leukemia is a rare subtype of AML and accounts for about 10% of cases, 10 to 15% of cases, and we can think that in Europe we have APL diagnosed in about 450 patients per year. In APL, the T15-17 translocation and the PML RAR rearrangement play a significant role. And the leukemogenic activity of this rearrangement is based on the retinoic acid receptor alpha, which is rearranged with PML. And this induces a repression of RAR alpha target genes and the differentiation block, which is typical of the disease. On the other hand, PML rearranged to RAR alpha loses its activity on senescence and apoptosis, and the result is then an increased self-renewal. For this disease, we have for the first time, we've had some years ago now, for the first time, a targeted treatment, which is based on two drugs which are able to target the two moieties in the translocations, ATRA, targeting this retinoic acid receptor alpha, and arsenic trioxide, which targets PML. The result of the treatment of the combination is the activation of differentiation due to pharmacologic doses of ATRA, and also the reactivation of apoptosis due to the activity of all-trans retinoic acid. Few additional mutations have been described in acute promyelocytic leukemia, and this is also due to this strong leukemogenic activity of the translocation. Some mutations in RAR alpha and PML genes have been rarely described, and these mutations have been associated with resistance to ATRA and also to ATO, also giving also a reason for the importance of these two moieties. The outcome of APL has been improving significantly over the years. The pre-ATRA era, where the prognosis of APL was about 20% survival at 5 years. With the addition of ATRA to conventional chemotherapy starting in the 90s, we have seen a significant improvement in survival. And in this situation, high-risk APL have been defined. These were cases of APL with increased white blood cell counts, over 10,000, and these patients had a significantly inferior prognosis when treated with ATRA and chemotherapy, which was idarubicin in most cases. Later on, with the development of the combination, chemo-free combination of ATRA plus arsenic trioxide, outcome significantly improved starting in 2006. And this was the time when the ATRA-ATO combination was used for patients relapsing after conventional chemotherapy plus ATRA. Later on, we've had approval of ATRA-ATO as standard treatment for APL. The pivotal trial, published in the New England Journal of Medicine in 2013 by an Italian-German collaboration, and the trial was led by the late Francesco Lo Coco. This trial was based on the use of ATRA-ATO for induction plus 4 cycles of consolidation versus AIDA regimen, which consisted of 1 induction cycle plus 3 consolidation with chemotherapy and 2 years of maintenance treatment. At 6 years follow-up, the chemo-free treatment was associated with significantly higher event-free survival overall survival, achieving 98% with ATRA-ATO at 6 years versus 89% for the AIDA chemotherapy. This was associated with a significantly lower rate of short-term side effects, with a reduced probability of thrombocytopenia and neutropenia in patients treated with the chemo-free treatment, but also with an increased rate of leukocytosis due to the less toxic activity of ATRA-ATO, and also a higher rate of differentiation syndrome, and also with hepatic toxicity and QTc prolongation, which we learned to deal with later on. This trial led to the approval of the chemo-free regimen for standard risk APL in 2015 by first FDA and then EMA agencies. In this trial, MRD was incorporated, and we were able to show that patients receiving the ATRA-ATO combination, similar to what happens with AIDA chemotherapy, were all achieving MRD negativity after the third consolidation. The kinetics of ATRA-ATO was a little bit different from that of AIDA, in the sense that patients treated with ATRA-ATO, some patients were still positive for the PML RAR-alpha rearrangement after induction, but they all converted to MRD negativity after the third consolidation. And this then resulted, as you see here, in a significantly lower probability of relapse, only 1.7% in patients treated with ATRA-ATO versus 15% in patients treated with the AIDA chemotherapy. The NCRI AML-17 trial and other trials and also real-life studies confirmed superiority of the almost chemo-free regimen for APL as opposed to AIDA-like chemotherapy. Only the UK AML-17 regimen was based on a slightly different dosing of ATO, twice per week instead of 5 days per week as in the Italian-German trial. So the Harmony registry, which is a EU-funded project, and nowadays includes about 15,000 cases of acute myeloid leukemia, represented a very nice area where we could validate the results of APL trials in the real life and at longer follow-up. So we were able to analyze 1,400 patients with APL at a median follow-up of 5.5 years and up to 14 years. These patients were derived from clinical trials, and these were the APL 0406 trials and AML-17, and clinical practice from large European cooperative groups, including OVON, the AML study group, German, and SAL study group. Both these are German study groups, the Swedish cooperative groups, and more recently also the Australasian Leukemia and Lymphoma group. 43% of the patients, including in the Harmony APL registry, were treated with chemo-free ATRA-ATO versus 57% of the patients receiving AIDA-like chemotherapy. And 37% of the patients derived from clinical trial versus 63% from clinical practice. So we were also able to compare outcomes of these two patients. It is very clear a significantly superior outcome for patients treated with the chemo-free regimen. And the survival of patients treated with ATRA-ATO reached about 90% at 10 years versus 78% for AIDA-like chemotherapy. This was, of course, associated with an improved event-free survival and a reduced cumulative incidence of relapse, which is about 4% for ATRA-ATO versus 14% for AIDA-like chemotherapy. And among variables associated in the multivariable analysis for survival, for most outcome measures, ATRA-ATO treatment remains an independent prognostic factor for survival, overall event-free, and also for cumulative incidence of relapse. Other important factors are age, over 50 and even more over 70 years, a high risk score, and the clinical practice scenario. We really think that evaluation of these outcomes is also important for the AIDA-like chemotherapy regimen, since we know that this regimen is still used in many middle to low-income countries. But however, we took advantage of this cohort to look more specifically at patients treated with ATRA-ATO. Despite a higher incidence of differentiation syndrome, which accounts in these patients for about 10% and was associated with higher white blood cell counts and also higher age, there were no differences in event-free survival, overall survival, and cumulative incidence of relapse in the high versus standard SANS risk score. So for the first time, we have a regimen where high white blood cell counts do not play a significant prognostic role. And we saw also improved outcomes in clinical trials as expected, where also reporting is more accurate versus clinical practice. And however, outcomes were better in during the first years where the clinical trials were performed, as opposed to more recent years where we have more patients treated in the clinical practice scenario. So since this is a disease where we now achieve really long-term survival and high probability of survivorship issues become very important. And the GMEMA group with Fabio Efficace also devoted a lot of effort to study quality of life in APL. And what they were able to show was that the physical component of quality of life, including dyspnea, fatigue, and physical functioning, was also significantly improved in patients treated with ATRA-ATO as opposed to patients treated with the AIDA chemotherapy. And when looking at the patients receiving ATRA-ATO versus those in the general population not having APL, not receiving any chemotherapy, the physical functioning of these patients was similar to that of the general population, if not better. One particular issue I would like to point out is secondary leukemias, which are part, of course, of the problems that we see in patients who receive chemotherapy for a primary tumor. And after APL, treated with AIDA chemotherapy, there were about 2% of secondary leukemia onsetting at about 2 to 3 years from the APL treatment. And this was in the AIDA epoch. With ATRA-ATO, we don't really see secondary leukemias, and just few cases have been reported by the literature. So there are still, however, some open issues. One, I would say the most important, which still affects survival in these patients, is early death. You know that early death is mostly due to bleeding complications and infectious complications. Bleeding complications due to the disease itself. We know that there is hyperfibrinolysis in patients with APL. There is activation of endothelial cells, endothelial damage, and release of cytokines, which induce then differentiation syndrome and which induce also bleeding. So the rate of early death has been decreasing, but nowadays we still unfortunately have about 19% of early death. In the Harmony project we had a lot less, it was about 6%, but we should think that that is a registry and there is under-reporting in Harmony. And the second open issue I would like to discuss is high-risk APL. The ATRA regimen is not in label for high-risk APL, but we will see the results of the Apollo trial, which is a phase 3 randomized trial comparing AIDA like chemotherapy to ATRA plus 2 doses of Mylotarg. This is a pan-European trial. I have here a picture of a very nice statue from Lorenzo Bernini at Museo Borghese in Rome. And Rome is the place where many APL studies were performed in the Gimema and by Francesco Lo Coco. And in this statue, Daphne, a nymph, escapes from Apollo by transforming herself into a laurum tree. In our case, Apollo wins. The Apollo trial showed a significant advantage for the chemo-free regimen, also in high-risk APL. The last issue is oral arsenic. We know that oral arsenic has been used in many Chinese studies and also in the clinical practice, also by Australasian, by the APL Asian Consortium project. And this is a total oral combination. And you see here a very prolonged overall and event-free survival for patients treated with the total oral combination. This combination is particularly attractive for consolidation treatment, since, of course, we need to see, during consolidation, we need to see patients less in our outpatient clinics, and this will be we will save a lot of resources if the results would be confirmed. And I would like to thank all my collaborators. So I think we have time for a few questions.
So just one question. What do you think about the possibility of arsenium to penetrate blood barrier for meningeal localization of the disease?
Yes, actually it has been shown that arsenic trioxide penetrates the barriers, and so we don't see many extramedullary relapses in patients treated first line with arsenic trioxide. I think that this is an issue that we will have to deal with more with high-risk APL. So we are going to analyze our data on the Apollo trial, also looking into that. I can tell you that so far there is not, also the rate of early relapses up to 2 years of follow-up is decreased in ATRA treated high-risk APL patients, and this includes also extramedullary relapse. But you're right, frequently patients who relapse do show CNS localization, but there will be a minority of patients with that complication, but with ATRA first line should be less.